Welcome, I'm ظاهر and I'm going to present a seminar about the practice of ventilation and its association with the outcomes in acute brain injured patients. It is a cohort, multi-center, perspective observational study. It is published on Springer and PubMed by multiple authors and across multiple countries concerning multiple ICU units across different places. It describes the ventilator settings practice in mechanical and ventilated acute brain injured patients during intensive care unit stay. Differences across countries and in the presence and absence of high intracranial pressure to evaluate their association with clinical outcomes. Mechanical ventilation is crucial in managing acute brain injury patients in the ICU, but it may also contribute to secondary injury and mortality. Lung protective strategies, LPS, have improved outcomes in acute respiratory distress and non-acute respiratory distress populations, but acute brain injured patients are often excluded from studies due to concerns about their effects on cerebral physiology, such as hypercapnia and increased intracranial pressure, ICP. As a result, evidence on the best ventilatory practices for acute brain injured patients is lacking. Recent studies suggest increasing use of lung protective strategies in acute brain injured patients, but specific research is still needed. The objective is to describe the ventilator setting practices of incubated and mechanically ventilated brain injured adult patients during admission to ICU. The researchers further explored the differences in practice of mechanical ventilation across different countries and in the presence and absence of high intracranial pressure. Finally, the association between ventilator settings and clinical outcomes such as ICU and 6-month mortality. This flowchart shows the patients admitted and screened for eligibility. Initially, it was 2,136 patients. 41 were excluded due to reasons like withdrawal for medical decisions or withdrawal of consent. 10 of them had no data or information of mechanical ventilation recorded. So the real sample size that was collected was 2,095 patients, 74 ICUs in 26 countries, with 1,807 available 6-month Gauss law outcome with the Gauss information. The additional characteristic and descriptive statistic of ventilatory settings and pulmonary complications at admissions. Of course, not all the patients admitted were of perfect characteristics. We needed variety. So variety and comorbidities to reminisce of a real life setting. For example, a lot of them had hypertension, cardiac failure, diabetes, chronic kidney failure, hepatic cirrhosis, etc., etc. The study method, as mentioned earlier, is observational, multicentral perspective cohort study. The protocol was endorsed by the European Society of Intensive Care Medicine. The study collected data at admission daily until day 6 and on day 10 and 14. This included clinical information such as demographic, neurological status, neuroradiological scores, neuromonitoring methods, therapy intensity for managing intracranial hypertension, vital signs, and both neurological and systemic complications, with a focus on pulmonary issues like pneumonia and respiratory failure. Intracranial pressure ICP data was recorded daily, and ICP above 20 millimmercury was considered elevated. For follow-up, ICU and 6 months mortality data were tracked. ICU follow-up started at enrollment and ended at ICU discharge for death. 6-month mortality was followed up through structured phone interviews with patients or family members. Study methods also, continuous variables were described by median 25th and 75th percentiles, while categorical variables by absolute and relative frequencies. A linear mixed effect model was used to assess the profile over time of the ventilator setting parameters, with individual and country as random intercept effects, and age, sex, type of brain injury, GC motor score baseline ratio, and pupillary reactivity as fixed effects. Based on these models, we quantified the variance partition coefficient, the VPC, and the intra-class correlation coefficient, ICC. What they mean is the country level VPC describes the amount of total variability of every ventilator setting parameter due to the difference among countries, while the country level ICC represents the correlation among ventilation parameters in patients within the same countries. High values of the country level ICC close to 1 indicates high homogeneity among patients within the same country, while lower values close to 0 suggest lower country contextual effect. Now I'm gonna roll it over to my partner.
Hello, my name is Eihim and I'll be taking this from here. So, for the results of our study, significance on admission, 2,095 recruited patients with a median age of 58 with an interquartile range of 45 to 70 years, with 66.1% of them being male, to be noted, had a median plateau pressure P-plat of 15 with a range of 13 to 18, and a tidal volume over predicted body weight of 6.5 milliliters per kilogram, driving pressure of 9 with a range of 7 to 12, and a positive end expiratory pressure of 5, with no modifications in the case of increased intracranial pressure, which, as we defined before, or as I defined, any pressure that is elevated above 20 milliliters or millimeters of mercury is considered elevated in our study. So yeah, there was no case in that, or no modification in that. Significant differences in practices, however, were observed across different countries, meaning that the variance partition coefficient, or VPC, is close to 0, or close to or approaching 0 across different countries. The majority of these ventilator settings were associated with the ICU mortality, and the highest hazard ratio HR being for the P-plats, with an odds ratio of 1.5 and a 95% confidence interval of which has a range of 1.27 to 1.78, and that is one of the most important characteristics that we or the researchers measured. The results demonstrated, the most important thing to take from here is that the results demonstrated a consistent association with 6-month mortality, and a less clear association was observed for neurological outcomes, meaning that these lung protective strategies did play a significant role in changing the 6-month mortality of patients. However, their effect with the neurological health of the patients was not exactly that clear, so maybe they didn't affect the neurological health as much, but they certainly did change the mortality rate, which we will see coming up. In this slide right here, we have a table showing the results of the time-dependent Cox proportional hazard regression models for the ICU mortality. So basically what this is that the researchers applied a bunch of different lung protective strategies, as we can see here, for the patients, and they tried to see how they affected the ICU mortality and the 6-month mortality. This one is for the ICU specifically. So as we can see here, the number of ICU deaths before applying any lung protective strategy or without the lung protective strategies is a 335 ICU deaths, which dropped to a significant 158 deaths. So it was more or less 50 or 60% decrease in an ICU deaths, which is massive. that is a significant drop in ICU mortality, meaning that these lung protective strategies had a significant effect in raising the patient, the safety, the efficacy, and enhancing the clinical outcomes for our patients right here. And we also have, hold on. We also have this other table, which is also the results of the time-dependent Cox proportional hazard regression models. However, this one is for the 6-month mortality instead of the ICU mortality. As we can also see, with and without applying these strategies, before applying them or without applying them, the number of deaths is 431 deaths, and after applying these lung protective strategies, the number of deaths dropped to a staggering 182 deaths. Again, significant decrease, about 50% decrease in the number of deaths, something like that, 50-60%. So yeah, these lung protective strategies certainly did have a significant effect on improving the patient safety and clinical outcomes. As for the limitations in the study, well, first, considering that we define the study, or the study is an observational, prospective cohort, multi-central study, we cannot establish causality. So this study cannot tell us if these things are related, because we could not interfere with them. We just saw that the researchers just got the data and compared it using statistical models. So we cannot establish causality from such data. We can't link it. It's just, we just observed the numbers, and we can't be exactly sure if if the causality is certain in this study. So the results, they should be interpreted cautiously on the mortality. And despite the adjustments for the confounders, that is. Second things is that while the study was multi-center and planned, certain detailed data, particularly on the ICU ventilatory settings, were limited, being recorded only once daily. So perhaps that if the researchers could have managed to record them more than once daily, they could have gotten a more accurate results. This restricted the insight into dynamic changes. In addition, since clinical practices was not altered, because paralysis was not routinely applied, because we can't really just, paralyze our patients, obviously. So we could not really intervene. And this study is not an interventional study. It's just an observational study. And this might have affected the respiratory and ventilatory data, because we can't be sure that the respiration rate and other characteristics that are important to us could have been constant for the whole day when the researchers took those readings, because these patients are acute brain injured patients and they are in the ICU, meaning that their condition is extremely unstable, and that we cannot guarantee that these characteristics and these parameters can be constant throughout the whole day, and our one single reading in the whole day we can't be sure if it's an accurate reading. And last but certainly not least, the inclusion time frame for this study overlaps with the COVID-19 pandemic. And as we all know, the COVID-19 pandemic threw the whole world into chaos. Therefore, we cannot entirely exclude the possibility that this period influenced the occurrence of pulmonary complications due to the COVID-19 virus, or altered the workflows, resource allocations, or other pandemic-related factors which could have affected our study and our researchers and their ability to obtain or acquire an effective readings and effective results and data. As for the recommendations on what could have maybe improved this study, because the researchers certain detailed data, particularly on the ICU ventilator settings, were limited, being recorded only once daily, maybe the researchers again could have taken these sorts of parameters more than once daily to get a more accurate results, depending on how the conditions were. But so yeah, other than that, that's mostly it. And last but not least, thank you for listening. I hope you enjoyed it. Thank you.